We're ready?
Yep.
Okay. Good evening, everyone. Welcome to the November meeting of the Academy of Integrative Health and Medicine's Cleveland chapter. I'm Peter Geller. I co-lead the chapter with Dr. Amy Cipolla, who is right here as well. And Dr. Jacob Wolf is the chapter's outreach chair, and we're not sure if he's here just yet, but that's the crew. So I am pleased and honored to introduce our featured speaker tonight, Dr. David W. Miller, MD, L.Ac, who, as you all know, will be presenting on pediatric and adolescent long COVID, recognizing the epidemic in our midst. I'm going to touch on just a few relevant highlights of Dr. Miller's extensive professional bio, because if I did more, we'd be taking up a substantial portion of his speaking time. But Dr. Miller, who in my estimation can fairly be called something of a Renaissance man, and who has been a pioneer and a guiding force in multiple integrative medicine endeavors, is the founding medical director for Pediatric Integrative Medicine with Connor Whole Health and Rainbow Babies and Children's Hospital at University Hospitals here in Cleveland, Ohio. He serves as co-director of the Rainbow Pediatric Long COVID Recovery Clinic, which is one of just a few such facilities and one of the largest in the US, where he coordinates the inclusion of integrative medicine techniques into patient care plans. And Dr. Miller is one of the only physicians dually board certified in pediatrics by the American Board of Pediatrics and in traditional Chinese medicine by the National Certification Commission for Acupuncture and Oriental Medicine. Give me a second. Okay, I think I just wanted to mention one other thing, which is that apropos of that last credential, he is also the founding chair of the American Society of Acupuncturists, which, for those of you who are not acupuncturists, has acted to unify the dozens of state acupuncture societies in this country under one national organization that advocates for my profession far more effectively than any or all of the individual state societies could possibly do, even together. Anyway, just putting that plug in. In tonight's address, Dr. Miller will touch on the principal and most common clinical features of long COVID in the pediatric population, and we'll discuss how the condition has become so prevalent, yet remains so little recognized and poorly treated. And finally, we'll report on the experiences, lessons learned, and integrative strategies used thus far in the Rainbow Long COVID Recovery Clinic. If there are any questions or comments, please enter them in the chat, and Dr. Amy will get to them after Dr. Miller's address. And finally, if you're not on our mailing list and would like to be to hear about, to make sure that you get our newsletters to hear about future events that we have pretty much monthly, then Amy has a piece in the chat which tells you how to join our mailing list. And you can also alternatively send me an email and I'll put you on the list at petergeller.lac@gmail.com. So without further ado, here is Dr. Miller. David, the floor is yours.
All right. Thank you so much, Peter and Amy. I really appreciate the invitation. Pull the slides up here and get into presentation mode. There we go. All right, and thank you all for joining us. It's great to see some family actually too, and friends, and some of the wonderful students out in California too. It looks like we're here. I was just out teaching at Five Branches University, which was really delightful. And so this is a topic that has become near and dear to my heart. I didn't know it would because it didn't exist when I ended up taking the job here in Cleveland, which started about 1 week before COVID came. And so it's been an interesting ride. And a lot of what I'm going to talk about absolutely also applies to adults, but there's certain huge knowledge gaps still about long COVID, but definitely for your patients, family members, friends, or yourself who may be suffering from symptoms of this or this condition, I want to help you understand it and also understand some things that even though there's no identified definitive treatments for long COVID, we have found some interventions that actually make a massive difference for a lot of people. And so there's always that gap between being able to see something in clinic that's working and do that repetitively and then do it in an organized enough way to report on it so that then you can actually say, do this for long COVID. But part of the process is learning what we think is working and then moving to that next stage of measuring it more precisely so that we can do some reporting on it. And we hope to move to that stage in the next year to come. So no disclosures. And so today I want to help you understand the prevalence and impact of long COVID in the pediatric population, as well as the most common ways it presents and how to identify individuals with long COVID. I think this is one of the biggest problems is that we have, particularly in kids, a lot of kids out there who are somewhat languishing with symptoms, and they go to many providers, they go to their teachers, they go to their family or other individuals, often coaches and things like that, and they complain of being tired. I can't do it. I can't keep up. And people say, well, you're probably anxious, or you're trying to get out of school or whatever it is, and they're not recognizing that we actually have quite a significant syndrome on our hands. And then think about the treatment strategies that prioritize the use of both sort of mainstream methods and also holistic and integrative care options. So I want to start with a real case of a patient who's an 18-year-old young woman with abdominal pain. She presented to the hospital with abdominal pain. It was around the belly button and in the right upper quadrant. And she also presented with bad headache. So the pain began in January of 2023, and she was seen by the general pediatrician twice in the emergency department, the gastroenterology department, and in pain medicine. Like as is typical of situations like this, a lot of studies were done and testing was done, and not cheap ones at that, which is, an important consideration. She had a normal head MRI, all of these logical to do. They checked her gallbladder, they checked her heart with the EKG, they did an STD check just to be sure, abdominal CT, ultrasounds, and comprehensive metabolic panel, which just showed a little bit of a high blood sugar and a little bit of a low sodium, but really nothing that could explain her symptoms. She was placed on quite a number of medications, as is often the case. And we try many things too with people a lot of times, but, she was placed on nortriptyline, gabapentin, omeprazole, and Lexapro, and had received things like nerve blocks and such to try to help her pain. So she ended up coming to us and saying, I don't know what's going on, but can you, explore this with me to see if it might be long COVID. And on further questioning, she also had all of these new symptoms, which started simultaneous actually to the abdominal pain. So really that should have been kind of picked up on. But as you can see with this number of symptoms, sometimes it's hard to contextualize that. I think a lot of times if you're being seen in the emergency room, the focus is on what's the biggest, most dangerous thing happening. And the fact that you're tired with new napping after school isn't going to come up in conversation. But she had that. She also had what's called post-exertional malaise, where she would do something that normally wouldn't cause her to have tremendous problems, and she would have what we often call a crash, where all of her symptoms would get worse, and she would have to sleep for excessive amounts of time to recover. We see this a lot in the kids that we see, where sometimes they'll do something that you'd think any kid should be able to do. They'll go play a sport, they'll hang out with their friends, and then they sleep for 2 days, like really ridiculously long amounts of time sometimes. So she also had nausea and loose stool with intermittent diarrhea, sleep disruption. I'll point that one out because that's a biggie. Unusual body temperature fluctuations, which is also something we see kids that run these fevers. They're like 99.5 to like 100, 100.5. Nothing big enough to be super impressive, but still different and weird. Her anxiety kicked up, and then she was developing dizziness also that was consistent with a condition called orthostatic hypotension, where your blood pressure basically doesn't keep up with the need and drops in unusual situations. And so one of the questions we always ask people is, does the dizziness get worse in hot showers? Because not in every case, but in a majority of cases with orthostatic hypotension like this, the hot shower is a trigger. And the thought is potentially it dilates blood vessels on the external part of the body, pulls blood away from the heart, and stresses the cardiovascular system just enough to make the symptoms worse. And we've had 2 patients who actually fainted in showers and hit their heads. And, it's obviously one of the worst places to fall because it's all tile and glass for the most part. So it's an important safety thing to be aware of too. She was also developing new difficulty concentrating and brain fog, shortness of breath, intermittent wheezing. So she'd had COVID-19 4 weeks prior to the onset of her symptoms. She didn't get to us until 3 months after the onset of her symptoms. And this is part of the lack of sort of recognition of the condition on a timely enough basis. Although she actually came to us fairly quickly, we've had kids come in 1 to 2 years after their symptoms started. And we think that's, it's unfortunate for sure, but it's important to start early with care, because we do believe that starting early and interrupting things early can really help to rebalance the person at least somewhat, for sure, in that early time frame, but also decrease the impact on all sort of the collateral life lived experiences that people have, their schooling, their relationships, their mood, their sense of like, what's going on with me. It's very rough for a 14 or 15-year-old or 10-year-old or 11-year-old to have this type of disruption and not know what's going on. So what is long COVID? Well, long COVID is a heterogeneous multisystem condition. Still no precise definition, and this is still true. There are a number of organizations working to develop definitions of long COVID. In October of 2021, the World Health Organization proposed a clinical definition through a consensus process, saying it generally occurs about 3 months or, onset of COVID-19 with symptoms lasting at least 2 months and cannot be explained by an alternative diagnosis. National Institute for Health and Care Excellence published a guideline defining long COVID as signs and symptoms that continue or develop after acute COVID, including ongoing symptomatic COVID-19 from 4 to 12 weeks. So they start sooner, and post-COVID-19 syndrome, 12 weeks or more. And then other organizations such as the NIH also developed similar long COVID definitions, oftentimes using that 4-week mark as the marker. And this is one of the things we see is, so someone gets COVID and they feel sick with COVID and they're down for, 2, 3, 5, 10 days. And then oftentimes one of two patterns happens. They get better and they feel normal for a week or 2 weeks. And then all of a sudden these symptoms start creeping in. And the reason for that delay is thought to be the development potentially of an immune response that could be driving the long COVID presentation. And it sort of kicks in that amount of time. That's one theory why we get that gap. The other pattern that we see is that people will get long COVID and then they just go, or get COVID and then they just go straight into long, they like never get better. Some of their symptoms change. They don't feel quite as acutely ill, but things are just not right. And they just kind of never recover. And as I said, there's a number of organizations still working to really clarify this. And because these definitions are imprecise, it makes it hard to answer some other questions. Like, well, look at a question of like, what role does vaccination play in addressing either the prevention of or treatment of long COVID? And so there are studies out there that do this, but they're a little bit all over the place, partially because the tracking of long COVID is very imprecise. The identification of long COVID has been imprecise. And so to come up with real numbers of who has what and how does it affect them is difficult to do. Different names for people who are suffering from long COVID. They get long COVID, COVID long haulers, post-acute sequelae of COVID-19, or PASC is one. And all of these get used interchangeably and mean exactly the same thing. So how common is this condition? So it's a very busy slide. I use the highlights to hopefully take that down a few notches. But as I said, because of variable reporting and definitions, issues with testing, changing virus, pre and post vaccine situations. Like when we started seeing patients in the clinic, we started in March of 2021. So about a year after COVID hit, most of our patients were Delta patients. Everybody was masked still. There was a lot of testing going on. And so that was one sort of time frame of this. But as time went on, masking requirements went away. People stopped testing. Now we're seeing kids who, like, they never had a positive test, but they had a condition that could have been COVID, and or they had a known sick contact. But that sort of precision in who has this and who doesn't has really been lost, which is sort of unavoidable when something becomes, epidemic and pandemic, and just is sort of repetitively out there. The mutation of the virus also has changed presentation as well. So back when Delta was the predominant strain, we saw a lot of cases of, for example, loss of smell and taste, anosmia, and taste disruption called dysgeusia. And we have not seen that with Omicron. I think both my co-director, Amy Edwards, and I would both say that we haven't seen kids with new onset loss of taste and smell in well over a year, which is kind of fascinating too. So Delta was doing that kind of ferociously, and Omicron has not been doing that, which is great. Omicron in general is still causing long COVID. We're still seeing new cases that are most likely attributable to Omicron, but they don't seem to be as severe as the Delta cases were. So looking at this, there are estimates of the prevalence of this up to like 41%, almost 42%, 38% among another set of cohorts. The prevalence of long COVID was 25% in this study that looked at 8,300 publications with 80,000 children and adolescents. And then the prevalence of long COVID, but basically varied between studies from 4 to 66%. And typically you'll see papers reporting anywhere from like 1 to 70% of people have long COVID. And it depends on those definitions, and it does not reflect necessarily severity, because if someone has one mild condition that is, attributable to a post-COVID experience, then they get classified as having long COVID. And one of the things that we've been looking at in our clinic, thanks to some generous donations, we were able to do some research on this and looking at the severity of symptoms and not just the absolute presence or absence of symptoms. So we'll talk about that in a little bit. So overall, the numbers are pretty rough, and I think we're going with somewhere between probably 10 and 30% seem to have some sort of a meaningful number of symptoms for at least a little while. We don't know how long it's going to last. We were hoping it wouldn't last very long, but we do have some kids who are going on their third year of symptoms. And so it can last quite a long time. So what causes long COVID? And there are still, again, this is a work in progress. There's new ideas coming out all the time. But this paper is really a wonderful paper, and it's very readable and very just sort of a nice layout of some of the thoughts on the causes of long COVID. That goes everything from immune dysregulation, which we very much believe we're seeing. People feel like they have the flu all the time. One of the things that I notice too is when I get the COVID vaccine, I have a really strong reaction to it. And so I am knocked out for the weekend. Like, I got a plan around that because I'm not going to feel good. And the only explanation for my symptoms is an immune reaction. Because I obviously have not developed an autoimmune problem, and I've not this, and then it goes away almost like a shutoff valve in about, sort of 36 to 48 hours. It just kind of clears up and I'm back to normal. So I can replicate quite a number of long COVID symptoms each time I get vaccinated, and then they go away completely. There's also thought that there's a disruption to the microbiome, the good bacteria that live in your gut. And a recent paper also just came out talking about a theory that serotonin disruption is actually profoundly involved potentially in long COVID, as it can underscore the function of a lot of different systems that look like they're separate from one another, but things like nausea, gastrointestinal problems, difficulty with the blood pressure maintenance, anxiety, depression. They're saying, a serotonin imbalance can tie a lot of this together. And that probably is a piece of the picture. I don't know that it's going to end up being the whole picture, but it is a piece. But that microbiome disruption is something that we believe we see quite considerably. And there are studies showing that there is persistence of virus in the gut tissue that can last for an unknown amount of time. Other things are things like autoimmunity and immune priming, meaning, does the illness cause your body to develop antibodies that then attack your own body? The virus enters through the ACE2 receptors, which are involved with blood pressure and things like that. These receptors and blood vessel dilation in the direction of blood. These are receptors that are present in pretty much every tissue in every organ. And so all you have to do is disrupt that receptor everywhere to have a multisystem condition. And so that may also be one of the things going on. And this may vary from person to person. There's some thoughts about abnormal blood clotting with micro blood clots that might account for some of the pain and fatigue and some of those symptoms. And then dysfunctional neurologic signaling, which we absolutely see. Dysautonomia, which we'll talk about, is a massive problem and very, very prevalent in this population among people who never had that before. There are certain populations who seem to be more vulnerable to at least the dysautonomia component of long COVID. And for example, those are people with connective tissue issues. So if you have Ehlers-Danlos syndrome, we see a lot of people who have some variant of hypermobile Ehlers-Danlos that seem to have a more severe case presentation and course. So there are certainly some correlations there, but the absolute mechanisms remain unknown. So we do see some differences between adults and kids in long COVID and in COVID itself. But with the initial infection in adults, you see a lot more things like pulmonary embolism, cardiac arrest, heart failure, like really life-threatening things. Death, nothing more life-threatening than death. So we definitely know that that is a case for the adults, and thank goodness we have not seen that in the kids. That does not seem to be the presentation in our patient population. Long COVID, dysautonomia, and what's called myalgic encephalomyelitis / chronic fatigue syndrome, MECFS, which is basically, you've probably all heard of chronic fatigue syndrome. It was sort of renamed to MECFS some years ago, and describes a complex set of problems and challenges that are extremely similar to long COVID, to the degree that one study was mentioning that 50% of people with long COVID would meet diagnostic criteria for MECFS. And the MECFS, the myalgic encephalomyelitis chronic fatigue syndrome, the origins of that are largely believed to be related to viral infections that leave the person changed in ways that again are like long COVID, exactly like long COVID. So there may be other things that can cause MECFS. There almost certainly are things like chemical exposures, extreme stressors, life stressors, things that really can knock sort of the immune system out of whack. But certainly we've known you can get these syndromes from things like Lyme disease or flu or Epstein-Barr virus or cytomegalovirus. For years, we've known that, but the numbers of people with that have been relatively low. So this poor population has presented many times to physicians, over the years, and they've gotten mostly brushed off, and again told that this is emotional, you probably have anxiety, et cetera, and so forth. But in reality, they basically had what is essentially long COVID, but no one knew enough about that to believe them. So I've talked to many people in the MECFS community who are like, well, one great thing that long COVID did was it made us legitimate. Like people now can say, wow, this is actually a real syndrome, and hopefully some real research will go into it and some real solutions will come out of that. So we see that presentation in both children and adults. That's very similar. Breakthrough infections, you absolutely see that in kids, but again, the pulmonary components, the severe coagulative problems, the cardiomyopathies, things like that, aspects of that, again, we're not seeing in the kids yet, knock on wood. We hope we never will. And so there is some severity differences between adults and kids, which again makes them, it's great that there's a severity differences, but it also makes them less obvious, and it makes the search for a solution somewhat less urgent. And so they may not be getting the care that they really need and the research that they deserve. So there's no definitive curative treatment available at this time for long COVID, but as I will talk about, we have found things that make it better. And so, I feel like people who have this condition should feel hopeful that there are things they can do to change their current clinical course. Generally, though, the aims of treatment are symptom management, although our clinic has taken a philosophy of incorporating health optimization strategies in addition to symptom management, meaning we feel that if we can set the stage for the immune system, for the psychologic system, for all the pieces of someone's living that makes them healthy anyway, if we can reestablish that baseline, then the best chance we have for curing them is for their bodies to be able to cure themselves. And so, we try to do things like correct any nutrient deficiencies that might be there. We'll talk about this, help recover their sleep, help with emotional regulation, all of these pieces that we know help to establish a healthy immune system and may help the person sort of basically kick this off, we hope. So right now, the Agency for Healthcare Research and Quality from the U.S. Department of Health and Human Services have an open comment period on their document called Long COVID Models of Care, which I read, which is it's a very nice document. It basically summarizes the strategies for caring for people with long COVID among clinics around the country. Not all the clinics, they didn't ask us. And mostly adult clinics. There were 4 pediatric clinics that they talked to. But their conclusions thus far are that many features of long COVID resemble those observed in ME/CFS. And I've underscored that a couple of times because a lot of what we had decided to do in our clinic was to draw from the ME/CFS literature to find out what worked for that population. Because we saw early on, not just us, many people saw early on that these syndromes clearly were overlapping one another. And it was actually this document that was quoting another study that said approximately 50% of people with long COVID meet criteria for ME/CFS. And the extent to which long COVID represents a form of ME/CFS is uncertain. However, given the experience, managing ME/CFS may inform the management of long COVID, which was the same conclusion that we came to when we were starting to get going. So just like there's no definitive treatment, there are no definitive lab tests that really need to be done. There was a study that came out recently talking about doing cortisol testing, AM cortisol, and that they were seeing a dip in AM cortisol, low AM cortisol, which is reflective of your body's ability to sort of keep your blood pressure up and your get up and go hormone in their in the population they studied. I sort of am like, maybe we've tested AM cortisol in a number of our patients, and it's not consistently low. I actually have 2 people recently who I ran that and the ACTH on, and they were actually a little high. And so, which is a little bit of a conundrum, but so we can absolutely have long COVID with a normal or elevated cortisol and ACTH. So it doesn't present itself really as a conclusive test. But we started out doing a lot more testing when we were seeing people because we didn't know what was going on, and it is a diagnosis of exclusion. And then we pared back on that after a year or so of really gaining clinical experience and just focus on the things that are most likely. If we see a presentation that really looks like thyroid issues, we test thyroid. We almost always test vitamin D and iron levels because those are both frequently low and we can fix them. And so again, in that spirit of health optimization, we want to fix any pieces that we can fix. We don't need anybody being vitamin D deficient while they try to recover from long COVID. So complete blood counts, metabolic panels, things like that. Very seldom at this point do we do any MRIs or CT scans, ultrasounds. It's just not indicated. We will occasionally do more EKGs to study cardiac function because there's such frequent complaints of chest pain with fatigue, but the chest pain is almost always musculoskeletal, myofascial in nature. Autoimmune markers are not highly correlative, and it's interesting that things like their SED rates and their CRPs, which are measures of systemic full body inflammation, are often normal, which is a little mind-blowing given how sick these kids are, and somewhat confusing as well. But it is what it is. It's what we find. There are some panels looking at things like interleukin levels and some other of those chemicals given off by the white blood cells when they're hyperactivated, but they're not readily available and they're expensive. And so we can't really draw them on everyone as part of sort of a screening panel, nor have they really been validated as reliable and useful in that way. So really the diagnosis is a clinical diagnosis. People often ask also, what role does the vaccine play in COVID long haul? And this is also sort of a great question, but with somewhat indistinct answers. So I pulled up a few studies talking about this. First question is, does it prevent long COVID? Overall, among the studies done, it looks like there is about a 29% lower risk, so 20 to 30% lower risk of developing long COVID if you're vaccinated versus non-vaccinated. Now, this gets confusing as well. Is that with Delta? Is that with Omicron? Is that with which subvariant of Omicron? And at what stage of this? If people have had coronavirus previously and then they get vaccinated, does it still protect them the same way? That nuance is not available. But in general, there seems to be some protective advantage of getting the vaccine. Now, does the vaccine alter the course of long COVID? That's another question. There was an interesting study of 28,000 participants, so that's really, pretty significant in size. And the first and second vaccine dose were associated actually with an improvement in long COVID symptomatology as that study defined it. And we have heard this among the patient base as well, that sometimes people get the vaccine and they feel like a bunch of their symptoms clear up. And so that's great. Other studies evaluating this one evaluated 380 vaccinated patients, found that 47% demonstrated no change in symptoms, 31% showed worsening of symptoms, and lastly, only 22% of patients felt better. And then another study of 83 healthcare workers found that 14 or 21% reported symptomatic improvement, 12% reported worsening, and 67% reported no change. So basically, we see those numbers are all over there. And I think what we can say conclusively is that in some people, symptoms will improve. In some people, symptoms may worsen. And for the majority of people, probably it won't impact the course of long COVID. And so that is clinically a little challenging to enact, as you can imagine, but we try to work with people and base, their prior experiences with getting vaccinated and such in helping them decide, do I get vaccinated, or at this point, do I get vaccine number 4, vaccine number 5, or, how do I think about doing that with my condition? So thanks to a generous donation by the Seymour Family Foundation, we were able to start doing a retrospective look at the patients in our clinic. So we pulled charts from all the patients who had seen myself, Dr. Edwards, and my colleague, Dr. Malik, between March 3rd of 2021 and June 20 of 2023. And we noted we had seen 250 patients. We had 1,177 office notes. And I will tell you, there were probably hundreds, if not more, calls and emails with patients in between, trying to provide them support. But it gives you sort of an idea of the size of the patient base. To compare that, sort of the sickle cell program at the hospital has somewhere between 150 and 200 patients in that program. And so this is a large population of kids. Interestingly, most of them are falling between ages 12 and 18. And so we are really seeing this as a problem of the double digits. There are very few kids we've seen who are less than 11 years. Most of the ones less there are going to be 10 or 11, maybe 9, but it does seem to be a problem that gets more severe around puberty. And then the greater than 19 is a little bit of we don't see as many of those kids. We have a small cohort of patients who are a little bit older. They've either been with us or they were in the pediatric system for other reasons, but we also have an adult COVID recovery clinic at UH. And so mostly the adult patients will go to the adult clinic, and we're seeing this age group. So there are a sizable number of adults as well. Again, those double digits seem to be the target for the greatest problems. In our group, we're seeing about 2/3 female, 1/3 male, which actually aligns with some of the national statistics. What does not align is that we have 81% a white population who've utilized the clinic, and only 6.8% Black or African American. And just to give you a sense, like the Cleveland demographic area, it's largely white, and African American is the patient population, with about being, I believe, somewhere around 52% African American and 48% white within. I mean, it's not exactly that, because we do have other races in there too, but gross proportions in the metropolitan area. The surrounding areas can be less diverse and such, but we do know that this is a red flag, that we are not reaching underserved populations, or we're not somehow getting the messages out to people of color, because the statistics from who gets sick with coronavirus tell us that people of color often have more severe and more prevalent illness. And so we should be seeing at least as many, if not more, of them in the clinic. So this is a challenge of clinic delivery, which actually is reflected in a number of other studies about clinics around the country. So common symptoms and unusual symptoms. So this is what we found from our patient base. 81% had fatigue. And, some of these may be a little bit underestimated even, but this is based on our search criteria of the charts. That's what we found. And so that is your number one presenting symptom. It's probably rare to have long COVID without fatigue, although we also have to ask, if you have symptoms without fatigue, are you not recognizing that you have long COVID, and are you not presenting? And hence our numbers are skewed because of that. These are the hard questions that are rough to answer. We also see this crazy number of people with headaches, and I would add the abdominal pain in there. The abdominal pain is this sort of around the belly button, often below the belly button, sometimes radiating into the lower abdomen pain. and headache that actually matches some myofascial symptoms that I'll show you, syndromes that that we'll talk about, and why we're getting this constellation of these things. I mean, lots of people have headaches from musculoskeletal issues, myofascial issues, but the combination of the headaches and the abdominal pain is quite interesting. Anxiety also spikes in unusual ways, and so we do have a lot of people who had anxiety before they had long COVID, but then they get COVID and long COVID, and their anxiety goes through the roof, and it's out of proportion to the situation. Like, sure, they're stressed, yes, they're situationally nervous, but the anxiety is very biochemical, and that might point back to that serotonin deficiency problem that may be underlying a lot of the symptoms. The dizziness we're seeing is mostly orthostatic in nature. So this is described more as someone feeling woozy. They feel like they're seeing spots in front of their eyes, like things are going dark, like they're going to faint. They're kind of doing this. It's not a vertigo, room spinning kind of dizziness. I think we've had one or two people with dizziness that would be described more as vertigo. This is really that orthostatic dizziness. And then some fever, brain fog's very common, and gastrointestinal disruption otherwise. I want to point a couple of other symptoms out that are interesting. So loss of taste and smell, again, we haven't seen that very much since Delta. A good number of our people would have been infected with Delta, and so we had some numbers of people we were treating for a while for that. But if you see that, that is fairly pathognomonic for long COVID from Delta. So someone who had that, there are very few things that have caused that or are causing that these days. Post-exertional malaise, again, that's that different type of getting tired where you do something that shouldn't make you that tired and you crash and you have more pain, you can't wake up, you just feel awful. If a patient is describing that, or if you are experiencing that, that's a high red flag for long COVID, or at least for ME/CFS. It's a very unusual symptom, and so it helps to identify things. That's cervicalgia, neck pain, back pain, we talked about, and then POTS or dysautonomia. We have about 20% of our population captured here, but I would actually, this is some of the ways we're still trying to crunch the data, because the dizziness I mentioned here with our 150 patients is also bordering on that same kind of dysautonomia. And so drawing distinctions with those, POTS is sort of a formal definition that actually has some different features potentially of some of the orthostatic dizziness. And so, but those overlap considerably, and I would say that our numbers are more along the lines of 60 to 70% of people have some aspect of that. And then two, I want to point out two symptoms that are rarer, but are both unusual and just they're just really strange. One is called functional neurologic disorders, and including non-epileptic seizures, where these folks look like they're having full-on tonic-clonic grand mal epilepsy, and you put them under an EEG and scan them, while they're having an event, and brainwaves are totally normal. And so that is a condition that was known before long COVID, for sure. And then functional neurologic disorders are people have these movement things, and we've had children, and even when I always remember one patient's mom saying, I woke up and I was just there, and then my legs felt like concrete and I couldn't move them, and I couldn't walk for a few weeks. And we've had a number of patients with that same thing, unusual movements as well. And I just would say, like, I had not seen that condition maybe more than once in 15 years of practice, 18 years of practice before long COVID. And now we have 9 patients with this that appeared within a year. And so even though it's not as common, it's profoundly disruptive and very hard to treat. And so also just kind of, fascinating. Visual snow is a visual symptom where people feel like they're watching the world as if it were pixelated on a TV screen, as if, for those who remember when the screens went dark at night and you get the white snow on the TV screen, it's like everything is a little bit like that. And that's thought to be related to changes in visual processing. There's nothing wrong with their retinas. There's nothing wrong with their optic nerves that people can see when we send them to ophthalmology. And so this is a diagnosis of exclusion, and then also this sort of central processing issue, as probably, clearly is the functional neurologic disorders is also a processing issue. So dysautonomia is a combination or constellation of symptoms that can involve almost any organ system. And this can be mild or it can be severe. And so we have kids who can't get out of wheelchairs. We have, people also have just sort of a touch of this where their like hands and legs turn funny colors at various times. They get the orthostatic intolerance, migraines, brain fog, difficulty there, weird eye pupil things. Sort of your nervous system just sort of goes haywire, and the balance between the sympathetic and parasympathetic stops communicating well. And so, the rehab for this is different than typical. So one of the reasons it's important to identify it and to also think about that post-exertional malaise component is that people with this combination need very specialized rehabilitation, because if they go to a typical sort of physical therapy appointment, the philosophy is more like do a couple more, just push your way through it and you'll be better. And what ends up happening with these people is they just crash. They push a little harder and they're down for 2 or 3 days. And then that actually perpetuates the cycle of illness. And we very much believe that these crashes perpetuate the illness. And so we want to interrupt those whenever we can. And so you have to do a really graduated movement, graduated effort, physical therapy approach. And fortunately, we've had some great folks here at UH to work with who have taken those lessons, and some really great folks from New York who were willing to educate our team on what they're doing there with their protocols to help people using physical therapy rehab. Aquatherapy also tends to be a really great rehab method for these folks, taking the gravity off and adding all that proprioceptive information about where your body is in space from the water seems to help a lot with rehab also. So we're also involved with a collaborative that was started by a group out of the Netherlands called the International Pediatric Post-COVID Condition in Children Collaboration, the IP4C, involving 10 different care cohorts from different countries around the world. Still big underrepresented regions, Africa, parts of South Asia, we don't have a lot of information on, but it's been interesting to collaborate with this group. And, basically what we've learned is that we're all seeing fairly similar patterns of what's going on. So they asked us to report on us early on some of the things we were seeing and look at the sort of similarities and differences. And there are some differences for sure, but there are also vast similarities among what people were seeing. So we did a retrospective look initially, thanks to Dr. Edwards predominantly, of our first 60 patients. And just to report that the typical number of presentations, the most common number of symptoms people would present with is 10 symptoms. So they thought they were just crazy. Like they were embarrassed to tell us, I also have this symptom. I also have that symptom, because they're just like, I can't possibly have all these symptoms. But the case patient I talked about earlier, the young woman who presented, she had fatigue, post-exertional malaise, headache, all these things. She had all of these as her real presentation. And that's one of your big red flags. You have someone who didn't have all this stuff presenting all of a sudden with all of these things going wrong. And while it's many things, and studies have shown things like from 20 to 200 symptoms, these are the most common symptoms. And so you're looking for sort of constellations of those things. If you have presentation in near conjunction to a coronavirus infection, that's helpful. But nowadays, I think we're seeing more asymptomatic cases. We don't always know that we have that connection anymore. But that's one of the biggest things is 5 people presenting with either 5 symptoms as their average presentation, but even more people presenting with 10 symptoms at the time of presentation. So this is a table I put together from some of our research too. It is pre-publication. And just to say the dots should actually be little like boxes, but I couldn't make those all pretty like our data analysts could do. But it begs the point. I wanted to give you the sense of this. So the blue dots represent a healthy cohort, just healthy kids. The purple are kids undergoing cancer treatment, and the black dots are type 1 kids with type 1 diabetes. And then the red boxes are our population. This is 66 kids in our group filled out what's called the PedsQL survey, and that has different domains that you can ask people questions about. And so these were filled out at their time of presentation to the long COVID clinic. So they were self-selectedly like sick and seeking care, and asked questions about general well-being, total fatigue, general fatigue, sleep and rest issues, and cognitive fatigue. And so in this type of a scale, numbers to the right are better. You feel better. So general well-being is higher. It's a little confusing. Like total fatigue is actually less when you go to the right. They feel better. They have less total fatigue. So we're seeing that the long COVID pediatric population actually has symptom severity that exceeds kids undergoing cancer treatment and kids with type 1 diabetes, at their time of presentation. These are severely impaired kids in many cases. This is another type of a survey called the PROMISE survey, and we had to find other studies that had used these surveys in the right age group populations. And looking at sleep disturbance, for example, and sleep-related impairment, we found comparison groups in, again, cancer treatment, also patients entering a sleep clinic for help with sleep problems, and kids with autism. In this study, 50% is kind of the norm, and then the farther you get to the right, the worse your symptoms get. So again, this population of long COVID, their sleep disturbance and sleep-related impairment exceeds even kids presenting in a sleep clinic for problems. So this is a big problem we deal with, is sleep disruption, which is very challenging. These kids also have anxiety and depression, which exceeds the norms for that study. We look at the types of specialists involved, and we see this in that report from AHRQ as well, is that there are a massive number of people who get recruited to try to help in these cases. So this is very much a multidisciplinary condition, and and I would encourage that it is multidisciplinary and ideally integrative too. And we'll talk about that now, because essentially I would consider long COVID the quintessential integrative medicine condition. This condition, it disrupts everything. It disrupts their physical health, their digestive health, their sleep, their ability to eat, and their nutrition is critical for getting them better. Their social connections are disrupted. Their schools are disrupted. They don't know how to exercise. We have to use techniques, mind-body techniques, different types of ways of sort of helping them understand their condition. It's everything that we do in integrative medicine is really approach this as a whole person condition. And so one of the things that our clinic does is we act as a center for all of the different people these kids see, to try to give them some cohesion in their medical experience, because otherwise you go to this specialist and they look at this little slice, and that specialist look at that little slice, and no one's really coordinating care in that model, and you just have to have someone coordinating care. So what is integrative medicine and health? This is from actually the Academic Consortium's version. I know you all share this this view, but reaffirms the importance of relationship between practitioner and patient. And this has been incredibly important to many of our patients, and is a role that you all can play as well. Is, they feel alone, they feel isolated, they don't know what's going on, and that's scary, and that makes it all worse. And so if you can act as a guidepost and an informer for your patients and follow them in their journey, that's very, very helpful. It focuses on the whole person and exploring intersecting causes of illness, emphasis on preventative care, informed by evidence, but including the full evidence-based pyramid, and informed by physiology. Like we can't wait for large-scale studies to be done on every type of thing before we try, because they're never going to be done, and people are sick right now. So I'll talk about how we think about some of that evidence in a moment, and then makes use of all appropriate therapeutic and lifestyle approaches in healthcare professionals and disciplines, and works to integrate care among specialties and detect gaps in care. So really, it's a team effort, and really they need people on their side. So as I've said, in our population too, we've really taken the position of wanting to optimize people's health. And I just use the picture of the plants in the sun. Like, if you want a plant to grow, you need good soil, you need good water, you need good light, you need all of these pieces to make the organism better. So what we're doing, these are sort of many of our give people stuff interventions, or it's somewhat do stuff with people too, and things we're recommending. So our top three are dietary modifications, a practice called pacing, and sleep hygiene. I'll talk about those three a little bit more. We encourage a lot of self-care wherever we can teach people to do self-care on themselves. We do, because that is empowering, and it also decreases the number of contacts they have to have with a provider with whom they have to make an appointment and bill their insurance and all this stuff, and take time away from whatever they're doing, including their parents have to do that. There's a lot of water and salt for the orthostatic hypotension people. Yoga can be a great rehabilitative practice. So we talked about that graduated like PT, where they do really gentle stuff. you can develop a yoga program for people that can be self-directed, that can provide that same type of autonomic nervous system rehabilitation. And then gua sha is another one that I'll talk about, some acupuncture, so many different things like that. We do use a targeted number of supplements. We've decided to put many people on a high potency multivitamin because again, these are adolescents. They're not eating brilliantly all of the time, and we can't have any gaps in their nutritional status. Probiotics have been very helpful for gut modification. A lot of people vitamin D deficient. Magnesium seems to be helpful for a lot of people as well. And so you can see sort of the list of the rest of these. Quercetin is an interesting one. Quercetin is a naturally occurring compound that's highest actually in capers. So if you like eating capers, you can get your daily dose of quercetin quite well. It's also high in apples and red onions, and you can also buy it as an inexpensive supplement. And quercetin is a chemical that stabilizes the mast cells, the cells that often are the main secretors of histamine in the body. It works like an old medication or similar to one called cromolyn sodium, which worked well for those things, but had to be taken 4 times a day. And so it sort of fell out of favor. And quercetin is a key ingredient in many of the sort of anti-allergy products on the market. And so that sometimes is a win for people to add that in. Niacin we use more early on due to some early studies suggesting that maybe it could be helpful as part of energy boosting. I think some people found it useful. But it causes flushing. The form you have to use it in is the flushing form. And so it can be uncomfortable. CBD and cannabis, we've just had a few people using. We have a prohibition on our providers at the hospital being too encouraging of or being the ones sort of signing off on people's use of that. So patients generally will come to us already using these. And so, we survey their experience. So I have one young man who I remember the family decided, based on the experience of one of their adult relatives, to try this because he still has, unfortunately, such a severe case. And that was the thing that worked best for him for one of his peripheral neuropathy symptoms, which was, he felt like he had pins and needles, like your foot's fallen asleep and it's waking up in that horrible feeling where you don't want to walk on it. He had that all the time. And cannabis basically took that away, which is fascinating. So it didn't do a whole bunch of other stuff, but that like gabapentin didn't do that, And so that was really interesting. And then to the right, you'll see the medications that we often use. We use a lot of anti-nausea medication, and Zofran has become like water to some degree. Fludrocortisone is a steroid, sort of a sibling to prednisone that tells your body to hold on to salt and water. That's been one of the most useful interventions for people with the orthostatic hypotension. A number of different antihistamines that are used. Hydroxyzine is an antihistamine, sort of a Benadryl sibling that has an anti-anxiety side effect to it that's very useful sometimes. And then some of the stimulant medications actually have been really helpful for brain fog and for energy to some degree also. These kids also, there are a number of SSRIs in here, again, begging the serotonin question, that they do seem to respond, not everybody, but many do seem to respond well for families wanting to use a pharmaceutical strategy to an SSRI support for a number of the symptoms. So it's interesting. The other one I want to mention is low-dose naltrexone, which I'll talk about later, which has been something we believe has been highly significant for a certain percentage of people who have used it. And at this time of this, we've used it in about 37 people and or 38 people. And I know we have probably about 5 or 10 more that we've been gaining experience on. So I'll talk about that. Evidence for integrative therapies and impacting, there are no, or really like minimal published randomized controlled trials of any of this. We really don't have mainstream treatment that people are like, definitely do this. So looking for integrative treatment is a little harder. So what we do is we look to the literature and we say, 50% of people qualify as having ME/CFS. What do we know from the ME/CFS literature? Because that condition has been around as an identified condition for 30, 40, 50 years. And so there are a number of studies that show that acupuncture can be a meaningful intervention for ME/CFS and for some of the dysautonomias that we see out there, fatigue, shortness of breath, anxiety, a lot of those types of components that are such a part of long COVID. And the adult clinic actually here has been doing a lot more referral to the acupuncturists in our program because they are finding their patients report really good outcomes, and so it's one of those things where if you have access to it and the financial means to access it, I would absolutely try it. and see if it's meaningful, for your patients, because in some percentage it will be a meaningful intervention. This is sort of a summary, and happy to share these slides after with anyone who'd be interested, of the interventions we do for sort of specific types of problems, whether it be fatigue or anxiety. A lot of mind-body work for the anxiety. We got to help people contextualize their anxiety and see through it, help them understand this is a biochemical phenomenon occurring in you, plus this is an anxiety-provoking experience. There is nothing wrong for you being anxious, in a sense, like, don't be anxious about being anxious, because then that becomes this vicious loop. Sometimes increasing salt and water is enough to deal with the dizziness. There's all sorts of aspects of this. But let me tell you a little more specifically for what our dietary recommendations are. We settled on a whole food, high nutrient density, high antioxidant, low simple carbohydrate diet. That's sort of the cornerstone of our diet. We felt strongly early on, based on some anecdotal history and a little bit of literature, that getting the sugar out was really important, including other forms of simple carbs, including like white potato, white bread, white pasta, white rice. Switch it over for whole grain, try to get more nutrient dense food, more complex carbohydrates. So we're not doing like low carbohydrate necessarily, but we're doing low simple carbohydrate. That said, there is some signal that sort of ketogenic diet strategies actually make people feel a lot better. And we just don't do that with kids because it's hard to do a ketogenic diet with kids, and moderating that really properly is virtually, we can barely get the kids to not eat a packaged food sometimes, much less eat a formal ketogenic diet. So that is a point of challenge, but they will oftentimes use smoothies. We can get that nutrient density in them. And for some of the, the evidence base behind this too, looking at the lifestyle medicine organization also has some great education on this and really summarizes the evidence base for it. So that was our approach. It does not appear that gluten is meaningful in this. It doesn't necessarily appear that dairy is a problem, that is. So we don't generally advocate for a gluten-free, dairy-free diet unless we have signs that someone is really having problems with gluten and dairy, which may have actually preceded long COVID, in which case we try to identify that, remove it from the mix so that that's not stressing their system. Core interventions of sleep hygiene, which is basically breaking the cycle of sleep disruption. These kids are tired, they're fatigued, they start sleeping all day, they can't sleep at night then, and so their circadian rhythm will sometimes flip completely, and they're sleeping all day and then they're up all night. And so we really have to get them into a very strict routine of trying to go to bed at the same time, get up at the same time, get the screens off an hour before, turn the room into a dark cave with a sound machine, and really do everything you can to optimize that sleep environment. And so this is a general sort of rules of sleep hygiene, but a high yield intervention when we can get people to do it. May not fix everything, but fixes a lot. And I've had kids who really thought they couldn't do this, including one 17-year-old with autism, and he did it. And he, we got to the point where it's like, you've got to do this. This is important. And we had a motivator of him trying to get to a training program he wanted to get to, and he pulled it off. And if he can pull it off, anybody can pull it off. And then pacing. So pacing is a strategy of energy management where basically what you're trying to do is you're trying to rest before you're tired. So this is one of those things that can be a hard concept to convey to especially young people who want to be going. We have one who we're always wrestling with because she feels like pacing is somehow a punishment, like it's pulling her out of the game. So we have to try to help her understand that this is so you can do more and not so that you are doing less. And so what we have done is worked with schools, worked with other programs to minimize the stressors on the kids. Like, they don't need to be running laps in gym class. That does not need to happen. And we integrate these 5 to 10 minute, not very long, 5 to 10 minute breaks throughout the day to do it before they get tired. So for example, I have one patient who loves going to Target, and she loves walking around Target. So she would go to Target for an hour and a half and come home and crash. And like, you can't do that. You can't be walking around Target for an hour and a half and crashing. But she can walk around Target for an hour and a half if every 15 minutes she takes a 5 to 10 minute break where she finds a bench, she sits, she closes her eyes, she breathes, and basically takes a rest and then gets up again. And that allows her to extend her activity level much longer without a crash. Another young man was doing about 3 days of school, Monday, Tuesday, Wednesday, and then crashing and not being able to get to school Thursday and Friday. We integrated pacing into his daily routine, and he was able to go to school for 5 days. We did a modified school program still, but it extended his battery considerably. This is an evidence-based strategy. It comes out of the ME CFS literature, and it doesn't cost a thing, and so that's fantastic. And there are actually apps you can get for your cell phone to help you do this. Some of the challenge of pacing is that physical, mental, and emotional stress can lead to a crash. And so, it may be that, doing this one activity one day was fine, but the next day it's not, because the next day you also had a math test, or you had a stressful friend event, or you didn't get a good night's sleep. And so it's really a process of learning to listen to your body's signals. And at the very moment you start feeling like you're pushing yourself, you have to stop and you have to take a break. People who integrate this in successfully have dramatic improvements. I just talked to a young woman yesterday who was very severe. The family actually came in from out of state. And maybe because of who they are, and maybe because they came in from out of state to talk to us, they actually implemented everything we said. And she's doing remarkably better. Like, she's not having any dizziness anymore. She's not having the headaches. Her GI tract is okay. She's sleeping better. Now they pulled her out of school and she's doing virtual school because the school couldn't accommodate all of the things we needed for pacing and all these things. But she feels really much, much better. And that is phenomenal. So there really is hope for significant improvement. For anxiety too, there's a lot of, this is a great spot for mind-body techniques, as well as psychiatry, psychology, SSRIs potentially too. But, if we can get kids doing any sort of meditation, yoga, acupuncture can be great for anxiety, Reiki, these kinds of things, but also perspective setting, taking a different view of, of what's going on. Some of the students will recognize I talk a lot with them about something called the post-spirits, and how your inner dialogues can take over your brain and make you worry about things and think you're getting all panicky about things, and you need to be able to step back from that inner dialogue, take some deep breaths, put it into context and set it aside, because they don't have the energy available to be that anxious, and it doesn't help them at all. So big needs for psycho-emotional support and regulation in general. The dizziness I mentioned, it's a type of a wilting feeling faint, black spots, not vertigo and spinning. There are a number of medications that can be used for this, but also starting non-pharmacologically with increased salt in water. The cardiologist will generally recommend 64 to 80 ounces of water per day for a typically sized adolescent, and 6 to 10 grams of salt in the diet. So it's very counter to what we typically think about trying to get the salt out. But these kids have low blood pressure, and they're dizzy from it. And if they can do this, it helps them a lot. Sometimes using rehydration solutions and such will help them get that flavor and the electrolytes they need as well. And it's easier for them to to restore that. And then, as I said, things like Tai Chi, Qigong, or yoga would be wonderful additions for care for particularly this symptom, as well as the anxiety and numerous other pieces. This was a case report on acupuncture and long COVID put out by our team here. I was not involved with this. This was a little bit more on the adult side. It was a 50-year-old woman. But for this woman, it's the acupuncture facilitated a significant recovery in post-COVID symptoms. And it's just a nice that they put out a case report talking about this, because especially at this level of experience, sometimes case reports are worth 1,000 words, so to speak. And they're a picture of someone who benefited. Doesn't mean it works for everybody, but sometimes an N of 1 is helpful. For the headaches, one of the best things I have found is myofascial care, and that involves using therapies and strategies from what's called trigger point therapy, myofascial trigger point therapy. But also in Chinese medicine, we use gua sha is a technique that we use that's a scraping technique. This is sometimes called Graston technique in the physical therapy world. Many of the chiropractors will also do gua sha or Graston, and we can teach patients to do it at home. But it's a technique that improves blood flow to the tissues. It releases tight myofascial bands, and I have seen really dramatic and fast relief in headache symptoms from families using this. So we have to know when the pain is from your myofascial system, and the things that help that. Things like stretching, massage is huge, hydration, proper nutrition, and then the manual techniques like cupping and gua sha can be really, really wonderful. And then this is an example of a trigger point in the trapezius muscles. This is often called TRP number 1. And the X is where the muscular dysfunction is, and the red area is the radiating pain pattern. So you get patients who come in complaining of, temporal headaches. That's a very frequent one. Behind the eye is another very frequent one that often goes with the clavicular branch of the sternocleidomastoid. And so if you treat this spot, the headache goes away, or at least improves. And so this is a strategy. You can also use acupuncture with that for sure, E-stem, depending on the type of practitioner you are or have available to you. But it's an important approach. These are other trigger point patterns that we see very frequently. This is that clavicular branch of the sternocleidomastoid, this frontal headache that's often described also as behind the eye, the sternal branch, and then this TRP number 1 are probably the most common headaches we see in, as you saw, like 60% of patients for whatever reason. It's very much sort of a wind strike kind of wind trap thing from a Chinese medical standpoint. But it is fascinating. Just a few more words on trigger points. I'm a big trigger point fan, I guess, or I don't like them, one of the two. But they're one of the most overlooked things, I think, in medicine for pain management. People get all sorts of workups, but no one looks for trigger points. These are real things. They're discrete focal hyperirritable spots located in top bands of skeletal muscle. This is a thermogram from the American Society for Regional Anesthesia and Pain Medicine. These are not schlocky people. I often get doctors going, I don't really believe in trigger points. It's like, you don't get to not believe in trigger points. These are a thing. And so you can visualize them that way, and we see them. And then this is some research from some of the esteemed folks in our field, Arya Nielsen and Ted Kapchuk, particularly noteworthy, talking about how gua sha increases microcirculation to locally treated areas. That increases circulation up to 4-fold. Upon use. And you see this immediately. I can do massage on someone for a long time, but I do a couple strokes of gua sha and the blood just goes right to the surface. Something about the mechanics of that help to get it done. There are also self-care techniques. I'm not going to play this now for time reasons, but you can find lots of really good, and this is a particularly good one, good self-care videos on YouTube. Share them with the patients, teach them to do self-care on themselves. For gastrointestinal imbalances, we use a range of things as well. The peppermint oil also has been particularly helpful for a lot of people. There's one from Now Foods actually that has peppermint, ginger, and fennel that I like a lot. The GI team seems to have fixed on IB Guard, which is just plain peppermint oil. And many patients do find that useful, and that's an over-the-counter, very safe thing that can be recommended by pretty much most practitioners. So probiotics, prebiotics, mag citrate, if oxalate or carbonate, if you are constipated, use a mag glycinate form if you do not want a laxative effect, and then other types of imbalances. We do tend to see constipation more than diarrhea. Lots of nausea, though. And then low-dose naltrexone is one that our learning curve has been great on, and it's a very fascinating chemical. Naltrexone is what you is the similar to naloxone. It's what you use Narcan for. It's using for opiate overdoses. So it's the pens they give out so that if someone takes too much heroin or fentanyl, you slap them with a pen and it blocks their opiate receptors. So this is not an opiate. It's the opposite of an opiate. It blocks those receptors. And it's been known, usually typically for those conditions for opiate overdoses, you use 50 to 300 milligrams. And it's been known since the 70s that when you use it in doses of 0.5 to about 4.5 milligrams, roughly speaking, it redirects a hyperactive immune system. There's some interesting studies on on the mechanisms of this that are sort of exceeds what we can talk about tonight, but definitely redirects the way sort of the immune system acts in secreting too many of these chemicals, including on cells called the glial cells, which may be why it can help with brain fog. So it's an inexpensive, safe thing to try and explore. And in some patients, it's really a game changer. Not in everybody, but in some it really is. We also use antihistamines and other things, CoQ10. I use Chinese herbal medicine when I can, and have found that to be useful at times for different people, different things. There's actually, I'm forgetting where it was published. It may have been in the Academy of Medical Acupuncture's journal. There was a nice case report also on actually the use of herbs for treatment of long COVID. And it was a case report talking about what they did. They did a pretty sophisticated herbal strategy with that patient with some, I believe, raw herbal formulas. That may not have been the source of it. I apologize, but a few case reports out there. So other resources that you can seek for more information are here. The longcovidkids.org is a nice community family organization that oftentimes helps provide meaningful relationship and community for people suffering from this. The CDC site is actually quite good for long COVID. Long COVID is an ADA protected condition. And so people have rights under the Americans with Disability Act if they have a diagnosis of long COVID. And that's really important for school compliance and sometimes other types of compliance, and then for the adults for work accommodations as needed. And then looking into the myalgic encephalomyelitis chronic fatigue syndrome community resources as well can be helpful. That will give you a lot more information on things like pacing and some of those strategies. This is a reasonably recent list of sites registered with long COVID families for pediatric COVID clinics around the country. This was the ones they could find at the time of seeking, various sizes, various contexts, some more private, some parts of hospitals, and sort of a work in progress. There needs to be a lot more communication among all of us doing this work, but that also requires funding and time and all of those kinds of aspects of chi that are not always plentiful. So this is our clinic, and we are happy to see patients from out of state, but unfortunately, unless they live in Illinois or Ohio, they do have to travel to Ohio to be seen once, at least in person, and then we can continue care remotely for long COVID for them. Myself and Dr. Edwards co-direct the clinic. Dan Goodall is our nurse extraordinaire, and Letitia Harris does a lot of our scheduling, and Dan can be reached through that email address. And then we have a team of folks who help in different departments who we've been trying to educate on long COVID so that they become our go-to people and they understand what we need. So Abby from nutrition has been fantastic teaching people how to do these diets and navigating that. Mary Alice from GI has a lot of knowledge of dysautonomia and her skills. Sally from sleep medicine, again, understanding how this fits into long COVID and what we're seeing as patterns, so people understand the greater context of what's going on. Dr. Malik and Dr. Makino helping with psychiatric care and some developmental behavioral peds care as well. So really nice team. We still seek other ones. We keep losing cardiologists here. We get them all trained up and then they go to a different location. And so that is the challenge, it turns out, of being at an academic medical center. But that is what I wanted to say. And then we can open it up for questions with the rest of our time. I'm going to stop the screen share here.
Thank you so much. We do have just a few questions in the chat, and if anyone else has questions, please make sure to share them. In the Q&A, Andrea just asked that if you would be willing to share a copy of slides to further her research. She didn't know that children were suffering from this condition. And then she also asked, how long do you follow with the children in the study? I'm curious to know the impact of long COVID and what, like, the impact on adulthood.
Well, I mean, that's a great question. I mean, this is, it's sort of a profound question we don't know the answer to yet, in the sense that these kids' lives have been dramatically disrupted in a critical developmental time frame. Many of them are in early adolescence. and experiencing, profound disruption of their ability to connect with peers, to go to school, to do activities that they love. And so there's a lot of mourning involved, a lot of loss involved in what's going on. We try to keep their spirits as up as we can, but it's challenging. And so, the full impact on how it's going to be for them as adults remains to be seen, but we would anticipate it will be highly significant for those with severe long COVID. There are probably many kids who have mild long COVID. When we looked at the number of people in the UH system, kids in the UH system who carried a diagnosis of long COVID, it was about 2,500 kids, not exactly 2,466 or something. But so we've seen roughly 10% of kids who ever presented to UH with long COVID and got a diagnosis. So we presume there's a certain number of those that were milder and got over it and are better. And we've seen lots of people get better, but we have a sizable number of people who are either profoundly ill or continue to have problems. And then they get sick again, they get better, and then they catch COVID again, and it rekindles it sometimes. And that's just devastating. And so you deal with anniversary reactions and just generally feeling like the sky is going to fall all the time. And so there's a lot of sort of unknowns about how that will impact them later on. We do try to develop a transition for our sort of adolescents and young adults transitioning to adulthood with the long COVID adult clinic so that they have connection there. But yeah, and I see the question of I don't have specific acupuncture points for this. I would gauge it on how the patient presents. They're going to present with profound fatigue. So, you might do, just your basic sort of like, stomach 36, spleen 3, UB 20, UB 13 would be reasonable to do, 42 would be reasonable to do, 17, Ren 12, those core like Ren 6, 4 points that support that core energy. But if they have headaches and pain, you're going to do a pain protocol. If they have nausea and constipation, you're going to do a protocol for that. So you definitely want to customize your treatment to their presentation. But I also think that there is a certain general support that acupuncture puts on, acupuncture allows as well by simply challenging the body to deal with sensory input and adjust itself and regulate and sort of go back to a baseline there. So I think there's also general effects that are valuable.
Great, thank you.
Sure.
All right, any other questions? I had a question just regarding your work. I know you said it was really hard to get kids to implement like a ketogenic diet. Have you guys seen what's the most impactful dietary change that people are willing to kind of
willing to do when they're willing to do it? Getting the sugar out seems to be a huge thing. That makes a big difference for a lot of people. Yeah,
that makes sense.
Yeah.
You could say that for adults as well.
Absolutely. If I were an adult with this, I would do all of these things. I would clean up my diet. I would regulate my sleep. I would practice pacing, and then, find providers who can help support in the other ways. Yeah. Oh, good. Yeah. Thank you for the comment there too. Yeah. It's a rough condition because people look healthy. That's the other thing the kids are frustrated with is we look well and everybody looks at us and they're like, you look healthy. And it's like, well, I know I look healthy, but I'm not healthy, and then we do testing on them. Their labs don't come back weird, for the most part. A lot of patients are just like, give me an abnormal lab result, please, so that there's some sort of objective validation of this. And a lot of times it doesn't happen. And yet that's what we see. So what we can tell them is we have 250 kids who are reporting the same or similar, and you are not alone in this. And one of our next, hopefully one of our next steps will be to start some shared medical visits with this population so that they can be with each other, because I think that'll be actually more healing than talking to me or Dr. Edwards or any of our team. Just they need to talk to other peers who are living the same experience.
That's a great idea. I love that. There's so much success with that in other populations. I can only imagine with the kids how great that would be.
Do you think? I'm sorry. Do you think that is one of the main reasons that there is medical gaslighting? Is that, objectively, there doesn't seem to be anything that you can point to, and so therefore the easy go-to is, oh, it's in your head, or you just don't want to go to school, or things like that. Is that, you think, what?
I do. I think that that is a big piece of it. And then the other thing I think that drives that is the fact that, as we said, like these kids present with like 10 symptoms at once that are big, and it's like you don't have all that, because it's just people haven't really been seeing it before. And so they get disbelieved. Yeah, absolutely. But adults are experiencing this too. So it's not just the kids. A lot of adults will report essentially medical gaslighting as well. So
There's a question in the chat. I'm not sure if I fully understand it, but I think do you mean, or did you mean the patients suffer bowel movement and diarrhea and sweat during sleeping?
So I think that's more of a Chinese medicine type question. So we see more constipation than diarrhea. Some people will have diarrhea. I actually had one kid recently who actually he didn't have long COVID, but they came because he had basically what looked like he had long Lyme and was suffering from. It was kind of fascinating. From watery diarrhea with undigested food in the stool and fatigue, and actually a very short course of formula called Shenling Baizusan, and he was up playing soccer. So I was actually really taken aback by his improvement in that. So that was pretty wild. There is more, though, I would say more constipation involved than diarrhea, which just is maddening to patients, of course. The other thing is that a lot of the meds they get put on to deal with their nausea symptoms or some of their pain, like amitriptyline or these kinds of things, are constipating. And so sometimes we're fighting the meds a little bit and have to really work. But so for the constipation, my go-to cocktail is things like probiotics, heavy doses of prebiotics, mag citrate, and fiber, try to get them eating plant matter and drinking a lot of water. And a lot of times that will really, really help. And they prefer that to Miralax, and it's more restorative than Miralax. It helps actually regulate the microbiome, which is critical for so many things. There are quite a number of people who do get night sweats, and whether this is like a kidney yin deficiency pattern or not, it could even be like a food stagnation pattern because they're so backed up sometimes. It's hard to say. I do use Gerbai D11 with quite a number of people, and that often does help the night sweating. There's one person recently who did a better response to Tang than to the other one for Chinese herbs.
And then there's a question, they said this was very informative. How can students of acupuncture participate or learn these practices within the hospital system?
Yeah, that's a great question. We're not totally set up. There's rules around shadowing and how to arrange that we'd be happy to work on. I know both Dr. Edwards and I are enthusiastic. Like, we love to go talk about this and educate people on it. So feel free, invite either of us. We can do it, in person, or if you're at a distant hospital, we're happy to have a Zoom meeting and talk about it. Shadowing in the clinic itself is just a little more bulky in terms of like the rules around the hospital and the number of people who can be there at once. But we have had people shadow in the clinic as well.
Great, thank you. Well, thank you so much for being here
Appreciate it.
today.
It was a fantastic talk, so comprehensive and authoritative, as much as you can be with some with some of the vague things that you have to deal with. But it was wonderful. And when some people were asking about sharing slides, how can you make those available?
I'd be happy to print this out as a PDF, and I can send it to you, Peter, or you to Amy, and they can contact you for a copy, perhaps, if that is the best way to do it via this forum.
Yeah, that's fine with
Great.
me.
That sounds good.
And then before we go, I just want to say that, that's what I was going to say. If you want to join our chapter email list and find out about all of our talks and presentations and panel discussions, Amy just put it back again in the chat. And if you thought that this was a great talk, then come back and visit us in January, because we're going to have a panel discussion with Dr. Miller on another integrated pediatrics topic. December, we are taking off, but I will still have a newsletter where we're going to preview the coming year. So give us your address and you'll get that information from us too. So thank you so much again. I appreciate it so much. And if nobody has anything else, I guess we'll say goodnight then. Okay. Thank you.
Thank you again.
Good night.
Be well.
Thank you, guys. Have a great evening.
Bye-bye.